Good morning. Make sure y'all can hear me. Since we are going to be talking about sensory perception, hearing, vision. Everybody can hear me in the back? Good? All right, well, we'll get started. I think probably now that you all are in your clinicals, you're probably seeing some of these patients that have these issues already. Or if you're older like I am, or some of you younger, we already are wearing glasses, some of us hearing aids. So you'll be seeing these patients and taking care of stroke patients as well in the clinical setting. So sensory perception impacts safety, communication, and independence, especially for your stroke patients. So nurses play a role in recognizing and managing these changes. So these are our learning objectives. I'm not going to read them. I don't want to bore you, but we're going to talk about sensory deficit, sensory overload, and sensory deprivation, and identify some conditions that interfere with sensory input, discuss factors that affect that, some diagnostic testing that we do for that, and nursing interventions that we will do to help these patients when we care for them. So, what is sensory perception? Sensory perception is how the body receives, organizes, and interprets stimuli. That's our sight, our hearing, our touch, our taste, and our smell, and our kinesthetic sense, which is the awareness of movement of body parts without seeing them. I'm a kinesthetic learner, which is why I have to have this mic, because I'm always using my hands. And then stereognosis, which is the ability to recognize through touch without hearing or sight. And an example of that would be if you're putting your hand in a bag looking for your car keys, that is using that sense. Or with the kinesthetic, if you're typing and you don't have to look at your hands while you're typing, that is an example of that as well. So some types of sensory alterations. Deficit is when you have complete or partial loss or impairment of a sense, like vision. These are your patients that have cataracts or glaucoma. And sensory overload, who has that? Y'all have that? I have that at this point, being in school and working and having a life. Sensory overload, you'll see this a lot in your ICU patients with all the alarms going off. I know when I'm working in the ER, I'm a little bit ADD, if y'all can't tell, but the alarms, the monitors going off drive me insane. There's people yelling over here, the monitors are going off over here, so there's a lot going on. So think about how your patients feel in ICU when they're in there by themselves and all the alarms are going off. And then bright lights as well. And then sensory deprivation, where there's too little input and not enough stimulation, like your isolation or immobility patients who are on bed rest. So our goal is to assess which one applies to our patient and adapt their environment to maintain safety and comfort. So some nursing care for sensory deficit. And I know those of you who are in health assessment, I hear you guys saying this every time you're doing your checkoffs. You have any problems with your vision? Do you wear glasses? Do you wear contacts? Do you wear hearing aids? You want to ask your patient about changes in their senses. And does it affect their daily life? You want to make sure that you're ensuring their safety, they have good lighting, clear environment, and encourage them to wear their glasses and their hearing aids, because it's not going to help if they don't have those on. And then promote independence and communication. So identify which sense is affected, keep the environment consistent and safe while promoting patient independence. So I'm going to tell you guys a story. I'm not sure it's going to top the poop story from the elimination lecture, because that was pretty good. But when I was a new grad, I worked on med-surg tele for about 13 years. And I went in my patient's room, and it was a gentleman, I guess he was probably in his 70s. And I was getting his meds together. This was before we had the electronic health record, by the way. So we did everything on paper. And I turned around and he handed me his eye, okay? Right there in my hand. And my eyes can get pretty big. And that usually tells a story if I'm like, what the? And I said, what is this? And he said, oh, all you need to do is just clean it with saline and then I'll just pop it back in. Meanwhile, I look at him and his whole eye is out of the socket. And I'm probably sweating at this point a little bit, like asking myself, did I really want to go into this field of nursing? I'm not sure about this. It's weird. So anyway, he had a prosthetic eye. And back then, you just didn't see that all the time. So good story for you. It won't top the poop story, but I'll tell you some more stories in a minute too. So let's talk about vision. All right. So when you walk in your patient's room, hey, I'm Jill, I'm your student nurse today. Make sure you identify yourself because if they have a visual problem, they can't see you. So make sure that you're letting them know who you are when you enter the room. Stand in front of your patient, not at the head of the bed, because they need to be able to see you. If you're down there at the head of the bed and they already have a vision problem, they're not going to be able to see you well. So make sure that you stand in front of your patient. Explain the interventions before you do them. You want to do that anyway, but they can't see you. So you need to say, I'm going to do a quick assessment. I'm going to listen to your heart and your lungs. Let them know what you're doing. So as far as hearing, you want to face the patient when you're speaking. You want to kind of get eye level with them. This was really difficult with COVID because we had masks and our little hard of hearing patients could not, it was a nightmare. So make sure that you are facing the patient when you're speaking to them. Speak slowly. And I have to remind myself to slow down because I'm a quick talker sometimes. So make sure that you speak slowly to them. And you're going to want to remember this, low tone. You don't want to speak way up here in a high tone because they can't hear that well. So make sure that you have a low tone, and for the love of God, don't shout. That doesn't help at all. Just be there right where they can see you. Speak slowly and at a low tone. And minimize background noise. If you go in the room, the patient's TV is blaring. Hopefully it's in closed caption so they can read it. But make sure that you turn that off, turn it down, whatever you need to do so that patient can hear you. Get rid of the background noise. And remember, some of your patients are lip readers. I'm a lip reader, very much so. So I'm looking right at that patient when I'm talking to them. So just remember that some of them are lip readers. And communication boards are another example of how you can communicate with your patient. They can write it down for you if they can't hear you and the doctor's yelling at the 10th decibel of the world and you're like, that's not working. Get a communication board and use that with your patient. And when you get in your clinicals and then when you graduate, eventually, and you're taking care of these patients, you have the use of sign language interpreters as well. If they do sign language, then make sure that you get those sign language interpreters on your little rolling video parts that you have. That's a huge help so that you can communicate with your patient. All right, so what I want y'all to do, I want you to, in your seat, turn around and face the back of the room for me for a minute. Everybody just turn around. Stare at the wall. Do y'all like looking at that wall and hearing me talk up here and you can't see me? Some of you might like that, but imagine how your patients feel. This is how they feel. Like you're in their room, they can't see you. All you hear is your nurse talking. Okay, you can turn back around. Just a little exercise to get us going. And if I'm talking to you like this, can y'all hear me? Can y'all hear me at all? That's how your patient feels when they can't hear you. So just make sure that you're doing all those extra things to communicate with your patient. It is very essential. And you'll find that they will just love on you when they can hear you and they can see you. It is amazing the difference that it will make. All right. So this more is a little bit about primary prevention and secondary prevention that we're going to talk about now. So with the eyes, make sure that you're telling your patients to wear protective devices, sunglasses especially, goggles, the eye goggles. I've had a couple of patients come into the urgent care, the welders, and they have not been wearing their eye goggles, and they have actually ocular burns. And they have been sent to Prisma because that's where the eye doctors are in the ER most of the time. So just remember to teach them to wear their goggles. Encourage vision screening. That's a must. You need to tell them, have you got your eyes checked? Because you just totally failed the Snellen chart that you read for me. So make sure that you're encouraging vision screening. Provide large print, magnifying lenses. I have my boyfriend's grandmother, actually, she passed away back in the first part, actually the end of September. She had a stroke. So this is kind of right up my alley to talk about this. But I got her one of those magnifying lenses, the big one that has a light around it, so she could see her crossword puzzles because she had a visual deficit in one eye. And she just loved that little thing. It was $10 at Hammer's. If any of y'all shop at Hammer's, that's for old people. That's where I go a lot. So just so you know, they have good shoes if you ever need that. All right. And clear pathways, have night light so they can see. One thing I see a lot, and I'm going to talk about this in a minute, is we do not teach families to get rid of throw rugs in the home. Throw rugs will cause falls. And so that is a big thing with people who can't see and who have issues with balance and coordination. Get rid of the throw rugs. So with the ears, primary prevention, wear ear protection, especially if you have someone that works in a job that they're exposed to a lot of noise. Make sure that they're wearing their ear protection. I used to listen, and I still do, just so y'all know. I like rap music. I used to listen to a lot of it when I was your age in my car, and I have some hearing loss in my left ear because I turned the volume up so loud because of the bass, I like bass, that I'm supposed to wear a hearing aid, and I don't. So if y'all are ever talking to me and I tell my coworkers this, and I don't acknowledge you, I didn't hear you. So just tell me again. I don't want to wear my hearing aid. I've taken it out and listened to people's heart and lungs, and it aggravates me. So, with that being said, flashing smoke detectors. Why do you think that's important for people that can't hear? They're not going to hear it if it goes off, right? So if they see it flashing, they'll know that something is wrong. So that's something you can teach your patient. Ear irrigation. You see this a lot. We have a lot of these come into urgent care. I don't know how many times I've irrigated ears in my lifetime, but that causes what we call conductive hearing loss. There's something blocking it. It's something obstructing there. So if you irrigate that ear, the patient can hear, they will love you. They think you just saved their life. You're like, oh my God. And you're looking down and there's this ball of wax that you've gotten out and you're thinking, how in the heck did you have that in your ear and not know it? But they do. And then, like I said earlier, closed caption, you want to encourage that too so that they can see that. If they can't hear it, they can see it more than likely. And with touch, prevent falls. We talked about that. A lot of your diabetics may have what you call peripheral neuropathy. Y'all have heard that term before. So they have numbness, usually in their legs. And you want to make sure that you are teaching them good foot care. That is essential, especially drying between their toes, because a lot of times they don't do that. And they end up with maceration in between their toes, which causes skin breakdown. Make sure that you're teaching them that. And then with smell and taste, encourage oral hygiene. A lot of these patients are on medications that cause dry mouth. So if you can get rid of that medication, that's great. If not, you just want to teach them, have water nearby, mints, whatever, just to help with that. Season their food so they can taste it. Chew slowly. Again, smoke detectors. Smoking cessation is huge. We all know that smoking can damage the ability to taste and smell. So teaching your patient about smoking cessation is essential. There are a lot of free classes around, especially that Lexington offers, that have a pretty good percentage rate of smoking cessation, and it's free. We offer it at urgent care, and they come over there, and we also give out Nicoderm patches and Nicorette gum for free through the foundation. So take advantage of your resources if you have them for your patients. And then adequate ventilation as well. They're just some things that you can do. I love this. I have used this since I was in nursing school back in the 90s. So I use this all the time when I have patients who have visual impairment. And I will tell them, hey, Miss So-and-so, your carrots are at 9 o'clock. Your sausage is at 6 p.m., whatever, so that they know exactly where to go and where their food is located. I just wanted to show y'all this because you don't see it as often as you did back then, but I use this a lot of times with my patients. Just good. They know the clock. Excuse me. And make sure you have a clock in the room now that I said that, so that they know what time it is. All right, sensory overload, what we all have, what I've probably had this week as I've been doing this lecture. I'm doing a research presentation on Friday and everything else I have going on in my life. So yeah, we're a little overloaded. So when this happens, we can have anxiety, confusion, restlessness, even your patients, especially in ICU, they're very vulnerable to overload. And then deprivation, which boredom, withdrawal, excuse me, can cause confusion, anxiety, and hallucinations. And your ICU patients can have both overload and deprivation. And then interventions, you want to cluster their care. So do everything while you're in there, because not that we have time to go in our rooms every 5 minutes as nurses, but this can overload them, definitely. So cluster your care. Ensure they have a quiet environment, meaningful stimuli, group the meds and treatment together. And then of course here I put a clock as well, because you definitely want to make sure that they know what, can you imagine being in a room by yourself and not knowing what time it is? Got to be awful. So just make sure that you have that available. And with the time change, make sure you change the time. So provide rest and add engagement, like conversation, or like for isolated patients in music. Music is great. Guided imagery is great. So just some things that you can do to intervene. So some factors that affect sensory perception: age. Older adults have a slower response time or difficulty filtering noise. Illness, such as diabetes, that causes neuropathy. Medications, which we'll talk about in a second, that cause ototoxicity. Stress, and the environment is in the hospital setting. All of these influence sensory perception. And with your older adults, and I said this earlier, they can lose the ability to hear high frequency sounds, which is why you don't want to yell at them. And they usually can only detect sweet tastes as we age. We lose the ability to detect sour, salty, and bitter, which, I mean, I like sweet, so that's okay for me, but you know, we want to keep that in mind for our patients. And then medications, your mycins can be ototoxic. Vancomycin, gentamicin, those are two. Other medications like ibuprofen, aspirin, and your loop diuretics like Lasix. And I want to tell you a quick story about a patient that I had who was on, actually he wasn't on aspirin, he was taking goody powders. And he worked locally here in Lexington, and he came in and he was having tinnitus. Y'all know what that is? Ringing in the ears. The physician that we had couldn't really figure out why he had that. And I had a student with me at the time who was brilliant. And I said, you know, go in there and ask him what medications he takes. And we do this in triage anyway, but we all know not everybody does what they're supposed to do. So my student went in there and he said, well, I've been taking about 12 goody powders a day. Well, guess what he had? Aspirin toxicity. And he ended up going over to the ER and had to go on sodium bicarb drip, and you'll learn that down the road. But so if we wouldn't have asked him, we would not have known what was going on with him. So we figured it out. Even the doctor couldn't figure it out, but my student was right on it. So just a story to share with you. So NSAIDs and antibiotic, like I said, can cause ototoxicity and alterations in taste. Some diagnostic tests for sensory impairment. They can have hearing tests for hearing loss. They can also go and purchase the amplifiers without having a hearing test, just so you know. Hearing tests are quite expensive, can be. So a lot of people just buy the over-the-counter one so they can put on, and it magnifies the noise for them, makes it louder so they can hear. And you know, you always know when somebody has a hearing aid on because it'll be singing to you, and you just tell them, can you turn it down just a little bit, because we all can hear your, you know, that noise. It's really nice. And then MRIs, which can assess for issues with speech, touch, and smell. One thing to tell you about MRIs, if you have a patient who is going down for an MRI, they're usually pretty good, the MRI techs, about telling them to take off anything that's metal. So as a nurse, make sure that you're telling them that as well. One of our environmental services guys was cleaning our floors over at Little Lex, and he went in the MRI room with his cleaner, and it stuck to the side of the MRI machine, closed the MRI down for the rest of the day because he just wasn't thinking there. So when we walked by MRI, here was the floor cleaning machine attached to the side wall. It was lovely. So just remember, metal out before they have MRIs. And your technologists are usually pretty good, like I said, about having them take things out. But you would be surprised, y'all. People have piercings in places you never knew piercings would be. And you just need to make sure that they are removing these so that they don't have issues or get stuck, or Lord, forbid, something bad happen. And then swallowing tests to assess for potential aspiration. These are your speech therapists. This is what they do. This is what they're trained to do. You want to make sure, I know when I'm in the ER, if anyone comes in with dysphagia, which we'll talk about in a minute, I have a fire BPA that pops up and annoys me and drives me crazy. And it says that they have to be evaluated before they can eat or drink anything. So just know your speech therapists, and they are amazing. And I'll tell you a story in a minute when we get there too. I have so many stories. And then neurological exam for alteration in touch. They'll assess reflexes, do some sensation temperature detection studies. Nerve conduction studies for those who have any numbness, tingling. They can do those. You can send them to an ENT. They can do smell and taste tests. They can also insert a scope up in the nares. You've probably seen this, where they can look for any obstructions or anything that may be causing an alteration in the smell for the patient. And then vision tests, visual acuity, make sure you're doing those with that Snellen chart. All right, so conditions affecting sensory function: age, stroke, dementia, diabetes because of neuropathy, hypertension, ototoxic medications, which we've discussed a little bit about, and isolation affects sensory perception and processing. And just a quick note here, and you might want to remember this: social isolation can lead to depression. So remember to increase their socialization and promote their independence. Those are very important. All right, now we're going to switch roles, talk about stroke a little bit. I loved talking about stroke. You see this often. And I've noticed when you guys, those of you who are in health assessment, when you were doing your pronator drift checkoff, we use this all the time when assessing for strokes where I work, and in the ER as well. So it comes in handy. You'll see this when you're in practice. So what is a stroke? Sudden interruption of blood flow to the brain that causes neurological deficits. It could be sensory, could be motor, or cognitive impairment. And the focus is on nursing care, safety, and adaptation. And just remember, communication and supporting recovery are important, because not all of your stroke patients are going to fully recover. This might be their new way of life. So you need to make sure that you're adapting to that and supporting recovery, teaching the family, making sure you communicate with the patient. All of these are very important for your stroke patient. Some changes that you might see after a stroke: unilateral neglect, that means one-sided. And someone asked me this question the other day. I thought it was a good question, so I'm going to throw it in here. It said, if you have a stroke on the left side of your brain, why do you have a right-sided deficit? Can y'all tell me that? I hear you. I hear you whispering out there. So if you have a stroke on the left side, your nerves cross over in the brain stem. So that's why you're going to have deficits on the right side. Some people don't know that. So it's good to know why. And then hemianopsia, which is the loss of half of the visual field. Aphasia, which we'll talk a little more about in a minute. There's actually 3 types. I learned 2 back in the day, but there are 3. Expressive aphasia, which they can understand, but they have an inability to respond or say words that they want to. And then receptive aphasia, and I always remember this as receiving. Receptive aphasia is where they speak, but you cannot understand them. It is complete word salad. And then altered sensation and impaired proprioception. That's the body's ability to sense its own movements and position. And it affects coordination and balance. So patients may ignore one side of their body or environment. Nursing interventions focus on safety and awareness. So when you go into your patient's room, just a side note, you're helping feed them, which we'll talk about in a minute. Just make sure you know, if you're helping feed a patient, put the food on their which side? Unaffected side, right? Because you don't want to put it on their affected side because they're probably going to aspirate and then you're going to have a bigger problem in the world. So just remember that. I like this little picture here. It tells you the 2 different areas in the brain where strokes can occur. The Broca's area, which is located in the frontal lobe, and if y'all can see that, it's purple, should be on yours. This area is associated with speech production, and damage to this area results in expressive aphasia. So the patient may respond with short answers such as walk dog. It won't be, can you please go walk the dog? It's going to be walk dog. Like, okay. And then the Wernicke's area, which is in green, if you can see that, is located in the posterior hemisphere. This area is responsible for language comprehension, including spoken and written. The damage to this area results in receptive aphasia. And like I said earlier, this may result in word salad. And then the 3rd type, and probably most devastational type, is global aphasia, which is a combination of all of this. It occurs when there is damage to both the Broca's and Wernicke's areas. This causes severe impairment of both language and comprehension. Probably the worst thing. I have seen one patient with this, and they did not fully recover. It was quite devastating. And they were young. I think they were like in their 50s. So just be aware of that and kind of what areas where and what it affects. Nursing priorities for safety and environment: approach from the unaffected side, which we talked a little bit about. You don't want to approach them on the affected side because they're not going to be able to do anything there. Put items within their reach. Encourage environmental scanning, and keep your setup consistent. This helps prevent accidents and fosters independence. You definitely want to promote their independence and their ADLs. Let them do what they can. Encourage self-care. Make sure they're using their adapted devices if they have them. If they don't, encourage them to get them. Give them extra time to respond. Simple language, definitely use simple language. And then we talked about earlier the use of picture and communication boards, and collaborate with therapy. This will reinforce recovery and confidence. You have a lot of resources out there and I'll talk about that here just because I think it's important. Speech therapy, physical therapy, occupational therapy are essential in stroke recovery. I used to manage a rehab unit after I worked the floor for a while, and I had a lot of stroke patients that I cared for. And if I didn't have PT, OT, and ST, my job could not be fulfilled and done, because they do a lot with these patients. Even once they're discharged home, your job as a nurse to make sure, get with your social worker and have these services arranged for in-home as well, because you want to maximize their full potential. Communication and education after a stroke. Use short, simple sentences, clear, and visual aids. Allow extra time for responses and be patient. And you want to teach the family communication strategies without frustrating the patient. And make sure that you involve the family, because they're essential in recovery as well. Even though they may get on your nerves, just make sure that you're teaching them. Think about how the patient feels, how frustrated they are with their family members. And just kind of intervene and help smooth that process. So you can teach them, and we're going to watch a video on this in just a second, have a little bit of fun. But patient and family education about FAST. That's facial drooping, arm weakness, speech difficulties, and calling 911 are all essential. You'll kind of hear in the hospital setting, be fast. We also use that, but you want to teach your family members fast. This is easy to teach them, and they'll remember it. So promote home safety, medication adherence, know the signs of a stroke, and emotional support. And again, move those rugs. I'll put that on here again as well. You want to empower your patients and their families. All right, this is pretty good, this video. I will tell you, I thought the actors and actresses did a phenomenal job. So it's just about 1 minute and 45 seconds. So let me play this.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up
Loud.
in the air for me.
Dad, are you okay?
Gracie, call 911.
I just...
Honey?
Oh, Dad!
Tim!
need an ambulance to 7th floor
Tim! Tim, look at me, Gracie. Tell them to hurry. Tim, look at me. Look at me, Tim.
Mom, what do I tell
Dad, I don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on, baby? My husband, he. I think he's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. I'm right here. Gracie, meet us there. I'm right here. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim? Tim?
Dad? Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
I love that video.
Now he's been wanting to put garlic chives in every...
When I first watched that video and they had that pause, I thought the man died. I was devastated. I was like, oh my gosh. And then they came back on, he was in the hospital. I was like, praise the Lord, he lived. That's a good day. So you'll see that. And time is brain. Time is brain, y'all. TPA, we use TKA a lot now instead of TPA. That's the clot buster, the medication that you want to ensure your patient gets within 4 and they kind of stretched it now to 6 hours. But it's essential that you know the last known well time of your patient, because that's when the clock gets ticking as to when they can have clot busting medication if it's not contraindicated. They don't have a bleed, then that's essential. So just make sure that you know when was the last time they were normal. And your family members are going to give you about 5 different answers, like I had the other day. I had a patient that came in and I said, when was her last normal time? 7:30 this morning. No, 3:30 this afternoon. No, last night at 9:30. I said, ma'am, do you need to step out? I need you to step out, and I need you to tell me exactly, calm down and take a breath. When was the last time you saw your daughter normal? Now, this girl was in her 40s. We sent her to the ER, and I just pray and hope that she did well. But she'd had a previous stroke from drug use. So just know your last time that they were normal is essential, because that starts your clock rolling for your clot buster medication. Yes? Well, think about it for a second. Drug use, what does it cause? Issues with the brain, for definite sure. Nerve damage, definitely. And that is what caused her initial stroke. I'm not sure which drug she was using. I didn't read that far in her chart, but her first stroke was caused from drug use. Am I echoing? Can y'all hear an echo? Okay. Yes, and I think he also had hypertension, so that might be what caused it as well. Drug use doesn't help that, but uncontrolled hypertension can definitely cause strokes because their blood pressure goes up sky high, everything shrinks, and there's your stroke that can occur. So blood pressure management is huge. Telling your patients to take their blood pressure medications is essential, because you don't want to see them laying in the bed and they can't move one side of their body, right? So preventing complications, again, assess swallowing before feeding. Make sure they're sitting up. You don't want to feed your patient or have them feeding themselves and they're at 30 degrees. That is not good. So make sure they are sitting straight up. And speech therapy, again, they're your go-tos for help in this area. Reposition every 2 hours, because we know that strokes, if you have a side that is affected, you're at risk for skin breakdown. So you want to make sure you're turning these patients. Prevent aspiration. Do not give them a straw, whatever you do. Straws will encourage and cause aspiration, but make sure no straws. You'll see a lot of speech therapists teaching them how to tuck their chin like this when they swallow, because it cuts off where you don't want the food to go, okay? So you'll see that. Small bites, of course, and then immobility, because they can be at risk for DVTs as well because of their immobility. And just a side note, and I'll tell you something interesting, aspiration is the cause of 60% of pneumonia after a stroke. That's pretty high. And the reason that is, and y'all learned kind of your anatomy, but your left lung is shaped like an L. Your right lung is shaped more like this. So if they're going to aspirate, they're probably going to aspirate in their right lung, because the food just goes completely down like this instead of like this in the left lung. So be aware, aspiration, and you see it often. Make sure that you have that suction at the bedside. We'll talk about that in a minute as well. So dysphagia, talk a little bit about that. That's a picture of a healthy swallow and then dysphagia. And dysphagia is difficulty swallowing. It's from damage to the nerve or muscle involved in swallowing after a stroke. So just a question for y'all now that we've been talking about this a little bit. Name one condition that your patient is at risk for with dysphagia. Yes, aspiration. And if you think about it, even though hopefully they'll be on top of this, but if your patient is at risk for aspiration and they're not really eating well, what does that put them at risk for? Yes, and dehydration. And then what are some interventions that you can do as a nurse, and more so when you're administering medications? Think along that line with your answer. What are some things that you think you can do for these patients? Correct. Change the route. What else? If it's crushable, crush it. If you don't know if it's crushable, check with your pharmacist. And you can put it in other things as well, applesauce, whatnot. But make sure that you're crushing your meds and then thicken liquids. And I'll tell you a quick story. I have so many. I'm trying to wind it up. But anyway, when I was the manager in rehab, I used to have to test all of the new products that came in, all of the thickened liquids that we got. And they brought tea with lemon in it. And I'm gonna tell y'all, if I have a stroke and I have to drink thickened tea with lemon, I'm gonna sign that darn waiver that says I'm just gonna aspirate, okay? Because it was horrible. And I said, if it's bad for me, I can't imagine what my patient thinks it tastes like. It was gross. The other things were pretty good. I like those, all the other thickened liquids. But the tea with lemon, I'm gonna have to sign that waiver and I'm just gonna have to aspirate and die and just be happy with my life, okay? So just be aware of that. You're gonna see that. You'll see, I don't know if they still put signs over the head of the bed with your stroke patients as well. You know, just said, keep the head of the bed up, or the patients on thickened liquids. You'll see it in your chart as well. So just something important to know. Any questions about that? Managing sensory overload during recovery. So you want to make sure that you provide a calm environment, rest, and there again, we see clear instruction. Explain the procedures clearly. Limit visitors, lights, and noise. And this is something you can do for your patients now. I do this often. You know, you give a patient pain medicine, turn their lights out, give them a warm blanket, let them go night-night and be nice and happy in the world. You can do that with just taking care of normal everyday patients. Be the nightingale in their life because, you know, we forget about these things. So just don't forget about that. So we're going to talk about Miss Lee, 72-year-old female who's had a left-sided stroke with right-sided weakness, visual field loss, and mild aphasia. So what do you guys think some of the safety risks would be for her? You could just yell them out. What's she going to be at risk for? She's got right-sided weakness, so what does that put her at risk for? Falls, yes. And she has got aphasia, so what does that put her at risk for? Aspiration. And then with the right-sided weakness as well, she's not able to move that side, so what is that going to put her at risk for? Immobility, skin breakdown, UTIs as well, because they can't move well. And depression, don't forget about depression. And then we talked about immobility with blood clots, DVTs. And then what are some things that you would do to promote safety and independence with this patient? What do you want to have available at the bedside for aspiration? Suction. What else do you want to give them before you leave their room? Call light. Do you want to put it in their affected side? Here's your call light. No, unaffected side. Monitor their skin because y'all are still doing the derm protocols, the Braden scale, and then turn every 2 hours. And what about side rails? I'm gonna put the side rails up. Probably a good idea. Encourage the family to stay at the bedside. Although family can sometimes get on your nerves, they are a huge help in some cases where your patients are confused and disoriented. So make sure that you're utilizing your family members as well. And again, we already said this, safety setup, communication aids, aspiration precautions, and emotional support. You want to promote clear communication, offer emotional support, and encourage teamwork with rehab services. And we're almost done. So key takeaways. Remember, sensory care is holistic. It impacts every aspect of care. And nurses assess, adapt, and educate to maintain safety and independence and dignity. Don't forget about dignity. Restorative and continuing care. Remember, your patients may not get back to their full function, so they need to be able to adapt to that, and you want to promote the highest level of functioning that they can do. Use your resources like we talked about, and encourage your patients to live a healthy lifestyle. Eat good, exercise, take their medications, manage their diabetes and hypertension so that we can prevent any adverse outcomes. And these are the references. Any questions?
Awesome.
Thanks, y'all. And I just want to say too, real quick, before I forget, I only have 3 weeks left and I'm done. I just want to tell you all how impressed I have been working with you all and how you've brought me out of my little shy. I know that's hard to think. I was shy, but you all have just kind of made me better and a better nurse and better person. And if I don't get to personally tell you the next 3 weeks, I just appreciate you all, and you all are so smart. And I'm so excited to see you out in the real world. So please, if you're going to be in the ER or urgent care, let me know. I'll hook you up, okay? And thanks again.